My name is Heinz Ludwig. I'm working at the Wilhelminen Cancer Research Institute in Vienna, Austria. And it's my pleasure to present on behalf of my colleagues the recent evaluation of the UVEA IXA study. The UVEA IXA study is a European multi-center observational longitudinal cohort study on the efficacy and tolerance of the combination of Ixazomib plus Revlimid dexamethasone in patients with relapsed refractory multiple myeloma. And the key objective of this study was to improve our understanding about the effectiveness and the tolerance of this regimen in real-world clinical practice. The study consisted of two phases. In phase one, patients were reviewed retrospectively whether they were treated with Ixazomib-Rev-Dex during the early access program, which was at that time open in Europe. And in phase two, the patients who had been were found to be eligible, were followed prospectively for 1 year, and data were assessed every 3 months. The median age of our patients is 68 years. The patient characteristics are shown in tables 2 and 4. And a total of 305 patients have been enrolled and assessed. And patients with cytogenetic features, those who had cytogenetic data available showed a high rate of patients with high-risk cytogenetics, namely 30%. And in general, the patients enrolled in this study had more adverse patient characteristics compared to those enrolled in the original TOURMALINE MM1 study, which compared, as you are all aware of, Ixazomib Revlimid dexamethasone with Revlimid dexamethasone. So patients had to have either 1, 2, or 3 prior lines of therapy, and had to be sensitive to lenalidomide, and there had to be a minimum treatment interval between the last treatment and enrollment of 3 months. Actually, the prior treatment, exposure to treatment, those patients was proteasome inhibitors was given to 50%, IMiDs to 20.1%, and a combination of IMiDs and proteasome inhibitors was given to 16.8% of patients before enrollment in the UVEA IXA study. The response rates are shown in graphic form and showed a high response rate in this pre-treated patient, namely 60%. Of those 60%, 11.6% of the patients presented with complete remission. 17.5% had very good partial response, and partial response was seen in 30.8%. The response rates were slightly higher, as expected, in patients with only 1 prior line of therapy as compared to those with 2 and 3 prior lines of therapy. The median PFS in the entire patient cohort was 15.6 months across all lines of therapy. Median PFS was 19.6 months in patients who had been exposed to 1 prior line of therapy, and median PFS was 13.9 months in patients with 2 or 3 prior lines of therapy. When you compare this data with the data obtained in the original phase 3 TOURMALINE MM1 study, we need to mention that in this study, in the TOURMALINE study, the overall response rate was 78%, and the median PFS was 20.6 months. with Ixazomib, lenalidomide, dexamethasone. The overall response rate was evaluated after a median follow-up of 20.5 months, and the overall survival, was 35.5 months overall. And again, overall survival was slightly, of course, superior in patients with one prior line of therapy, namely 43.1 months, as compared to those with 2 and 3 prior lines of therapy. The safety is shown in the e-poster and was assessed in patients who had at least 4 or more cycles of therapy. And figure 6 shows that 37% of the patients reported grade 3 or higher adverse events, and 19% reported a grade 3 or higher drug-related adverse event. In line with previous reports, the most common adverse events were hematologic and gastrointestinal, and that is shown in figure 7 of our poster. And it's important to note that the safety data are not directly comparable with clinical trial data due to the retrospective and partly retrospective nature of this study and the infrequent prospective collection of data. But in conclusion, the results of our study show that Ixazomib-based therapy are effective in real-world clinical practice. Overall response rate, as mentioned, was 60%, median PFS 35.5 months, and importantly, the tolerance of this regimen was very good, and so it's a regimen for people who prefer an oral regimen. It's a regimen which was effective in patients with high risk and standard risk cytogenetics, and it's a regimen which can be recommended for use in clinical practice with a high, let's say, activity and excellent tolerance profile. With that saying, I would like to thank you for your attention. Thank you very much, and I close here. Thank you very much.